Good afternoon, everyone. Buenas tardes, bienvenidos. Okay, we are in the home stretch, right? Maybe we can have a stretch to wake ourselves up after lunch. Okay, my name is Emma Roberts, and I am filling in for Gabriela Rodriguez, who is going to be the moderator for this session. Please let's send lots of positive energy for Gabriela, because she couldn't join us today. Some of you may have met me in other sessions. I did a wellbeing session on Monday, so I'm really excited to be asked to step in and moderate another wellbeing session, because it's something that's connected very closely to the work I'm doing, so I'm ready to learn lots from our esteemed panelists. My name's Emma Roberts. I've been doing harm reduction for almost 30 years now, both direct service and capacity building training and technical assistance. I'm not going to do long bios because we want to make as much use of the time available and allow our panelists to be able to share all their treasure with us. But today we have Svitlana from Ukraine with us. Give us a wave, Svitlana. We have Philin from Thailand. Yay. We have Emily from New Zealand. Marie from France. And Daniele from Geneva. So, without further ado, I'm going to ask our first presenter to step up, Svitlana. Thank you. Are you going to do it there, or you want to? Wherever you feel comfortable, we have a microphone.
Hello, do you hear me? Yeah?
Yes.
Dear colleagues, my name is Svitlana Moroz. I'm from Ukraine. I represent international regional organization operating in Eastern Europe and Central Asia countries, Eurasian Women's Network on AIDS. And my presentation will be based on result and findings of community-led assessment conducted in 3 countries of Central Asia, Kyrgyzstan, Kazakhstan, and Tajikistan. And I will share also with my colleagues who presented here the context of mental health of people who use new and synthetic substances in Central Asia. And next slide. So I will speak a little about the purpose of this assessment. First of all, we trying to understand the substance users' behaviors, associated HIV risk, interaction with health services, and unmet needs. It was conducted among people who use synthetic and new drugs in Kyrgyzstan, in 2 cities, Bishkek and Tosh, in Kazakhstan, in Ust-Kamenogorsk and Pavlodar, and in Tajikistan, Dushanbe city. And objective was to understand the spectrum of available substances and methods, describe how the use of the substances fits into the daily life of people who use drugs. Also, we examine the journey in a healthcare facility of people who use drugs. And of course, we will try to understand how we can better design HIV prevention services and harm reduction services for this group of people who use drugs. As I said before, it was conducted by Eurasian Women's Network on AIDS. It's a regional network of women living with HIV, women who use drugs, LBT women, sex workers, women who are mainly activists and doing advocacy-related activities in our region. And it was conducted in partnership with regional network Eurasian Association, Harm Reduction Association, and of course the key implementers and data collectors. It was community activists in 3 countries of Central Asia: Kyrgyzstan, Kazakhstan, and Tajikistan. And representative of one NGO here with us, and we also have possibility to learn from them how this assessment was conducted. We have a lot of questions during focus group discussion and interview. I repeat again that it was community-led. All focus group have community facilitators from drug users community, and interviews was conducted also by activists from community of people who use drugs in these 3 countries. So it was completely community-led, and we believe that this approach ensure more trustful relation between interviewer and interviewee. What we learn about psychoactive substances and daily lives of people who use synthetic and new substances in this country. First of all, participants reported difficulties in maintaining social skills and connection, the inability to maintain a social life, like planning, working, studying, going to stores, communicating with friends and relatives. This is usually caused by mental health issues resulting from substance use. In such status, people who use drugs avoid communication and prefer to be alone, which complicates the process of asking for help, and of course the possibility of providing and accepting this help. In order to hide the use of substances from their family member, some respondents leave home, sometimes for several days, and spend their night simply not in their houses, but in entrances, like apartment houses, and they just stay in these entrances. Based on the findings and results of our assessment, we can clearly state that SNPS certainly required special attention, and the vast majority of respondents reported that they had experienced psychosis, sleep disturbance, depression, and suicidal thoughts. It was like many cases of this during interview as well as during the focus group discussion. Study participants also reported phobias associated with open windows, closing the windows so as not to go the windows. We are also shocked by this data as well, and they even provide the real stories and real cases, like people under the substance use just went out the windows, and it has really shocking consequences for health and even death cases as well. We also need to mark codependent relations worsen in couples where both partners use substances. They reported big psychological abuse, and in some cases, unfortunately, they also reported sexual abuse as well. Professional help from narcologists or psychiatrists psychiatrist is rarely sought in cases of mental health issues. The quality of assistance provided is assessed differently. In some cases, when it's friendly doctor, it was good quality of help provided. In some cases, it was really discriminative and stigmatized behavioral. In many cases, this condition is expected to go away on its own. So people don't ask for help for professional help. And very important point about, so what's next? When we receive these findings, when we receive this result, not only related to mental health, but also how HIV treatment, HIV prevention, how harm reduction programs can be improved and adapted for the needs of new group of people who use drugs, like new and synthetic drug users in Central Asia. So for us, it will be really important to have follow-up for this assessment. And it's good that the donors receive major of our recommendation based of this assessment, and we have follow-up. The community-led organization in Kyrgyzstan, Attica, now provide specific services, including mental health services for people who use new and synthetic drugs in Kyrgyzstan. And these mental health services include not only peer-led services, which is of course very important, but also friendly psychologists and psychiatrists, including online consultation. If you need more information about this new design, integrated design, we have colleagues from community here, they can say more. And in our situation, it's very important to know that this assessment was supported by USAID and our partners like Family Health International. Thank you for your attention.
Thank you, Svitlana. And just to say, there's such a body of work from the Eurasian Harm Reduction Network. I know I've gone there and looked at that, so I'm so glad that you're adding some really new information to that body of work that we can all access to support us in understanding, right, the needs of the folks that we're working with. So thank you. Our next speaker is Philin from Thailand.
Well, สวัสดีตอนบ่ายนะคะก็ Good afternoon, everyone. My name is Philin. This is my friend Kaonachi. It's great to be here. I'm excited to be here and share with you about internalized stigma among people who use drugs in Thailand. Let me begin with some question. Have you ever felt lonely? Yes. Have you ever felt like you were not accepted? Yes. And have you ever experienced discrimination? Yes. If you answer yes, today we're going to talk about similar experience, but it's about people who use drugs in Thailand. A group of people who are often seen as bad people just because they use drugs. They are stigmatized and labeled, and ultimately they internalize that stigma, feeling unworthy. As a result, they stop taking care of themselves and lost opportunities, even their dreams. Okay. In Thailand, stigma and discriminations against people who use drugs are still major barriers, blocking their access to healthcare, employment, and social support. One of the most powerful, yet invisible, forms of stigma is what we call internalized stigma. It's that the deep sense of guilt, shame, and the loss of self-worth. And it doesn't just hurt, it silences. Many people are too afraid to even ask for help because they feel like they are a burden. They believe they don't deserve support, even when their lives are being violated. I remember one moment really clearly, and we developed our program. We test it in the northern area of Thailand. In one of the focus groups, a participant shared something really personal. He had serious problems with his eye, but he was afraid to go to the hospital. He was afraid the medical staff who judged him, looked down on him, or maybe even refused to teach him just because he used that. Can you imagine that? Being in pain, but feeling too ashamed to seek help for something you never asked for. Okay. This project is in collaboration with the Foundation for AIDS Rights, the Faculty of Nursing, Chulalongkorn University, and the Thai drug user TDN. We apply acceptance and commitment therapy, which focuses on self-acceptance, aligning with life value, and setting meaningful goals for change. Together with TDN, we developed community-led interventions program aimed at addressing internalized stigma with that using community. To better understand the context and needs of the target group, we conducted 4 focus group sessions. This discussion revealed how both external and internalized stigma significantly affect access to healthcare, employment, and social services. Additionally, communication dynamics within family or close relationships play a key role in the influencing drug use behavior. Our program was then tested in the 3 areas with distinct social, economic, occupational, and drug use context. Important and training is essential for service providers to understand stigma and discrimination and their impact on individuals. It helps us identify the barriers some groups face in society. Which are part of this discrimination process, there are 4 ranges to view the problem from different. The program includes 5 key activities, starting with activity 1, understanding craving and the brain-body connection. We help participants understand craving don't mean they are bad people. Craving happens because of how the brain and body work, especially how the brain links drug use with relief or comfort. We introduced idea of 2 brain systems, one that reacts emotionally and one that thinks more logically. Knowing this helps people see themselves with more compassion instead of blame. Activity 2, recognizing and learning about internalized stigma. We begin by reflecting on experience of stigma and discrimination, exploring the thoughts and feelings that arise from this experience, which often leads to negative perceptions of oneself. We all examine the effects of internalized stigma and work on motivating individuals to challenge and change those thoughts and feelings. In the following activity, we will introduce techniques to support this process. And activity 3, creating distance from internalized stigma through technique like we suggest a way to shift our thinking by comparing is to car passing in front of your house. Every day, many cars pass by without you really noticing. But when we focus and stare, we start to see each car more clearly. It's the same with thoughts about being stigmatized. If we don't focus all the way on them, we won't notice all the detail. Just let them pass by, like car driving by your house. This way, we don't have to hold on to those stigma. Another technique we use is turning a painful word into a song. One participant was called very hurtful name Kwai, which means buffalo, and is used as an insult in Thai instead of letting that word stay in his head and hurt him. He sang it to the tune of the Happy Birthday song. This made others laugh and help take away the power of insult. We invite you to try that. Pick a word that hurt you and sing it to a melody. Sometimes hearing being with a little playfulness. Activity 4, practicing mindfulness and noticing how our thoughts change in real time. Each person has their own way of staying present. Some people like me try to meditate and end up falling asleep. Others prefer coloring, moving their body, or doing light activity. There is no right way to do it. What matters is finding a way that helps you really be with yourself. For me, mindfulness is about getting to know my own thoughts, giving them a space, not pushing them away or judging them, just noticing, breathing, and if I can laugh with them a little, it will matter. Everyone has a different way to practice staying present. Activity 5, setting life goals and connecting them to relationships with family, friends, work, and self-care. During the activity, some participants share simple but meaningful goals, like wanting to have more meal time with their daughters. One participant who has trouble with their eye, he wants to see a doctor and ask a community staff member for help and support to make that happen. And important too, we use the Thai Internalized Stigma scale with 8 questions. If someone scores over 16, it means they are dealing with strong internalized stigma. The higher the score, the stronger that stigma, but it's not just a number. It helps us understand ourselves better and start healing from the inside. Okay. Lisa and Sheng, we started by training 24 staff and community leaders from Sick Harm Reduction Center, helping them get comfortable with using the internalized stigma screening tool. With their support, we lead 96 people through outreach and group sessions. Among them, 32 joined the full set of activity. And we didn't stop there. Follow-up and ongoing support we keep part of the process. Lesson learned. After screening 96 people, we found that 32 has very high internalized stigma score. Through the session, they learned to use techniques like creating distance from negative thoughts to manage their feelings in their daily life. In 5 cases where the stigma score were especially high, we worked with them to get connected to mental health service because their well-being needed to more attention and care. We also saw some meaningful shifts. 12 people shared that they felt mentally lighter, more at ease, and 2 participants even set personal goals like connecting with family or taking better care of their health. This may seem like small change, but for many, they are big steps forward. Okay. In just 3 months, 32 people with high internalized stigma participated in the program. Out of these, 14 show positive change in mental health, relationships, and access to healthcare services. What is interesting in that all 32 participants were able to manage their substance use to some extent, some reduced their usage, and a few even stopped using altogether. Alongside this, we saw a significant reduction in internalized stigma. This pilot project showed that community and civil society play a crucial role in reaching out to the target group. They can provide services that truly understand the context of people who use drugs, something that traditional healthcare systems often struggle to do. The key challenge is implementing this work is continuity. Ensuring sustainability requires strong collaboration between government, communities, and civil society. These partners are essential in reaching target groups and providing services that are grounded in an understanding of the lived experience of people who use drugs. From this small program, we are not only changing the life of some people, but also transforming ourselves. We are shifting the way the system sees the humanity of people who use drugs, leading to systemic change. What we are doing together, driven by the community, is turning a policy change into reality. We are creating a proven example that communities can manage on their own and deserve long-term support. Thank you so much. ขอบคุณค่ะ
Thank you so much, Philin. As someone who is asked all the time to do trainings about addressing internalized stigma, I really appreciate you sharing this approach and framework with us, right? Because I think many of us, also working in direct service, for me, for our participants, helping them to address that internalized stigma is one of the biggest things to helping them then, be ready to decide what they want to do in terms of their next steps and their life goals and recovery pathways and all those things. And if we don't address it, right, and they try to move on to that without doing that first, it's often really harder for them to achieve their goals. So thank you so much. Our next speaker is Emily.
So I got to time myself because I'm a real yapper. Tsena tato katoa. My name is Emily Hughes. I'm a Canadian who lives in Aotearoa, which you might know as New Zealand. I live on the indigenous land of Tangata Whenua Māori. I'm the principal science advisor at Te Puna Whakaiti Pai Mai Mai Kai Whakapiri, also known as the New Zealand Drug Foundation. And I have the privilege today to speak to you guys about neurodiversity and substance use, what we know about the connection between autism spectrum disorder, ADHD, and substance use, harm reduction, and treatment as well. And this is a topic that's really close to my heart as a person who has ADHD and uses drugs, but also as a person who loves lots of neurodivergent people who use drugs. So in saying that, if there's any neurodiverse fam in the room, and it's easier for you to listen to me standing up or fidgeting or stimming or walking around, or closing your eyes, full permission to do so. I know you probably saw me fidgeting over there. It's just how it goes. So I want to start with two things, and I know I have a lot to cover in a really short period of time, but it's quite important to talk about these two things for me first. One is that I want to acknowledge that the experiences of people who use drugs who are neurodiverse are really unique and really nuanced. And by no means what I'm talking about is going to apply to everyone who identifies with ASD or ADHD and substance use. And I also want to acknowledge that these are very different for Indigenous people, racial minorities, disabled people, refugees, women, and gender diverse folk, among others. And in Aotearoa, New Zealand, there's a huge inequity when it comes to the diagnosis and treatment of neurodiverse conditions for our Indigenous Māori, and even more so for Māori who also use drugs. And the second, which you see on the screen, possibly more uplifting thing, is that recently in New Zealand, we've come up with some kupu Māori. So this is words to describe these medicalized or clinicalized conditions. And I wanted to share them with you guys today because I think they're really beautiful and I think they frame up the discussion really well. So these were developed by a Māori educator and linguist called Keriopai. And these are the Māori kupu. So for ADHD, you can see on the side, it's erorere tini. And that most closely translates to attention goes to many things, which I very much relate to. And the kupu for ASD, autism spectrum disorder, is takiwatanga, which most closely translates to in his, her, or their own time and space, which I think is pretty freaking awesome. And so I thought I'd start with that because it's what we're going to talk about. There's some disparities, obviously, and so a lot of challenges for neurodiverse people who use drugs, but I think this is a really nice strengths-based way of phrasing the conversation. So many of you are probably familiar with autism spectrum disorder and ADHD, but I thought I'd pop up the clinical descriptors just in case. And of course, these aren't the only conditions that fall under the umbrella of neurodiversity, but they are the conditions where there is the most research that we were able to gather as part of our work. There's much less research when it comes to things like FASD that fall under that umbrella as well. So in October 2024, the New Zealand Drug Foundation released a report on substance use and harm in people with ADHD and ASD who use drugs. The report included a literature summary, community insights, and recommendations to help better understand the complex nature between neurodivergence and substance use. And we're really proud of this paper, and you can access it on our website. I've got my contact details at the bottom of the presentation. So there's not that much literature on the topic. In fact, there's actually far, far less than I would expect for something that seems, quite common. And it's something when I've talking to people at this conference, people are like, yes, of course, neurodiversity and substance use, there's a lot to explore there. But we actually found it really difficult to put together findings outside of treatment settings, which is what we were most interested in. But I've pulled out some of the kind of key things that we thought were important that we found in our report. Some of them for ADHD include 1 in 5 people with substance use disorder will meet the criteria for ADHD, whether or not they're diagnosed. People with ADHD are more likely to use drugs and to develop harmful or problematic use compared to the general population. And undiagnosed or untreated ADHD presents the highest risk for harm from substance use as well. And for autism spectrum disorder, diagnosis and treatment can be really challenging. People with ASD are actually less likely overall to use substances than the general population, but are more likely to experience harm from their use. And people with ASD have really high levels of attrition or dropping out from traditional treatment services, and we'll talk about that in a second. And co-occurring ASD and ADHD, as well as other mental health conditions, is common and can increase substance use behaviors as well. I also want to point out that I'm very aware that I'm going to be splitting these into ADHD and ASD, but I know that there's a huge, co-occurrence of those conditions. We've done it this way because it's easy to visualize and because it's what the literature does. They tend to not look at things co-occurring, but acknowledging the experience of our odd ADHD people in the audience as well. I know that there's a lot of crossover there. So what stood out really clearly in the literature is that people with ADHD are considerably more likely to engage in substance use and are more likely to engage in riskier substance use as well. Some of the key findings that I thought might be interesting for this audience, given your diverse perspectives, are things like illicit stimulant use is common in people with ADHD, and it's associated with self-medication. And the concurrent treatment of ADHD and substance use disorder is most effective. So substance use disorder intervention is really unlikely to be effective if somebody's ADHD isn't being treated generally with psychostimulant medication. And that improves the outcomes considerably, not just for their substance use, but for their overall health and well-being, which again, no surprises there, I'm sure. And one of the things that really stood out from my conversations with people in the community of people with ADHD who use drugs is that in Aotearoa, New Zealand, they felt that the diagnostic process was inaccessible, it was stigmatizing, and it just really wasn't suited to their needs, which was something that came across every single person that we spoke to, which was really, really staggering for us. And one of the reasons that's really interesting for us in Aotearoa, New Zealand, this is our wastewater data, is that stimulant use is is one of our major contributors to drug harm in New Zealand. And in particular, we have really high rates and rising rates, as you can see, of methamphetamine and cocaine use. And we also have a very, very low rate of diagnosis for ADHD. And of course, there's some research to suggest that people with undiagnosed and untreated ADHD may find relief from their symptoms by using stimulant substances, which again is no surprise because the medication used to treat ADHD are stimulant substances. Again, why I was surprised that there wasn't very much research on the topic. The most important part here is the community insights. So the stuff I'm going to share with you has all come from the community of people that we've spoken to about their experiences. We didn't have the resourcing to do a large-scale qualitative research, but we were able to have a small-scale qualitative engagement. And so you can just read some of the insights that we had up there. I won't read them all out to you. But yeah, really important to see that the experiences of people with neurodiversity and substance use were mostly that they felt the system really, really wasn't suited to their needs. Awesome. So I'm going to talk about treatment first, and then I'm going to talk about harm reduction. And one of the things that came out really clearly to us is that treatment services for substance use are not well suited for people who are neurodiverse. For ADHD, delayed gratification in residential services is not compatible. The lack of interoception, I'm not sure if you know it, but like the understanding what your body needs. I only know I need to pee when I desperately need to pee. I only know I'm hungry when I'm really hungry. That sensory overwhelm and lack of interoception can make restrictive treatment environments unbearable. For instance, in Aotearoa, in our residential services, you essentially have to have basically a group consensus if you want to go to the bathroom, and it's meant to build, group resilience. But for someone with ADHD, it's actually quite inhumane. Alternative models of treatment can be effective. We have a program that's very aptly named Speed Freaks in Aotearoa, New Zealand, and it's a peer-based, non-abstinent service where peers get together and talk about their substance use, but they do it while they're walking or running or doing exercise because people with ADHD like to move their bodies instead of sit in a room. So yeah, those kind of services do work really well for people. And we need to treat substance use disorder before, we need to make sure that we initiate psychostimulant therapy, so using drugs like methylphenidate, dexamphetamine, whilst we're treating substance use disorder. Expecting somebody to be abstinent of substances before you treat their ADHD is extremely counterproductive, but it's actually the clinical standard in most places in the world, including in New Zealand, which is really, really challenging for people with ADHD. And there's a chronic underdiagnosis of ADHD in people who use drugs, being labeled as drug seekers or not wanting to disclose their substance use, and that reflecting a difficulty in diagnosis. And this is especially true for Indigenous people, for women, for gender diverse people, for disabled people, for high masking individuals like I was for most of my life. And for autism spectrum disorder and treatment, sensory overwhelm, again, no surprise, is extremely common. The bright lights in this conference, I've talked to lots of people who are like, I can't focus because of the bright lights. I can't focus because of the sound of the translation and the speaker speaking. You can imagine that in a treatment service being really, really challenging. The substance use disorder screening tools that many of you who work in AOD probably know are not fit for purpose for ASD. The way that they describe people's experiences don't often reflect what people with ASD experience in their everyday life, and that came out really clearly from people we spoke to. And substance use can obscure timely diagnosis and support for ASD, especially in high-masking individuals, women, Indigenous people. And there's a general lack of knowledge in Aotearoa in the AOD sector, which means that attrition from services is really high. And there's very few, if any, in New Zealand, peer services for people with ASD who also use substances. They're very scarce, which makes it really challenging. I do want to afi that Smart Recovery in Australia just launched a group for people with autism spectrum disorder and substance use by people with autism spectrum disorder and substance use, which is so cool. And I think it's probably one of the first in the world. So I think that's really awesome if you get a chance to check it out. It gives me hope that things are changing in the right direction. And experiences of harm reduction. And this is actually the first time I'm talking about this, because after having conversations with people at this conference, I realized how important it is to have guidance on delivering harm reduction services to neurodiverse people. But for people with ADHD, services need to be available here and now. Planning can be really challenging. Anybody with ADHD in the house knows that it's hard to plan things ahead of time. So we need to make sure services are diverse, they're available everywhere. Think needle exchanges, it can't be one place in the city. It needs to be lots of different places, vending machines all the time. It can be really burdensome to manage rigorous schedules for interventions like medication-assisted treatment. People who have to show up for OST at the same time every single day. That's really hard for people with ADHD. And education on interactions between illicit drugs and psychostimulant medicines is super, super important, and it just doesn't really exist. And again, I'll repeat it several times because it's so important to me. Accessing treatment, whether or not someone is using drugs, is a #1 predictor for positive health outcomes for people with ADHD. There's one thing you take away today. I hope that it's that. And for autism spectrum disorder, harm reduction services and spaces can be very overwhelming, and low sensory environments are key. I run a drug checking service, and we recently opened a static service where we have low sensory spaces, and we've had a massive uptick in people with ASD coming in and going, I never wanted to go to your community clinics before. They're so stressful, the music's loud, it smells like weed, it's crazy. And they're like, I can come here and chill, and now I can use the service. So that's a real reflection for us that we still need to develop our services. Simply stopping substances for people with ASD that have a utility in managing their symptoms is not always the best choice. Sometimes abstinence is not always the best choice for people. And peers that intimately understand the intersection between ASD and substance use disorder can help provide that nuanced care. Information and advice needs to be available for people with ASD in a variety of modalities, as it should for all of us, but particularly with ASD, how people learn. Do they engage with written content or talking one-on-one or talking in a group or video content? We need to be dynamic, and we need to be able to develop our resources to suit the needs of people. And many of these things are also relevant for neurotypical people who use drugs, obviously, but it's even more salient for our neurodiverse family. I'm very aware that this was an extremely brief overview of a massive topic, and I would love if you guys had the opportunity to read the report. It is very long for a reason, and we cover quite a lot in that. But what I'd like to leave you with today, and probably the most important thing for me, is that neurodivergent people we're used to navigating a world that isn't made for us, people that don't share the same perspectives as us. And people who use drugs are used to navigating a world that makes them feel like they're less than. So I think the message that's most important for me is that we owe it to people existing in this intersection to adapt our systems to work for them and not the other way around. And to my community, to my neurodiverse whānau of people who use drugs, I love you, I see you, I hear you. Ngā mihi nui.
Thank you so much, Emily, for that. It was really inspiring. You know, I say a lot to people, you know, when we're doing harm reduction, it's about the tools that we have in our toolkit to tailor the way that we work with each individual in front of us. And I just feel like you've just given us some extra tools to our toolkit that we can use more of. So thank you very much for that. So our next speaker is Marie. I'll hand it over to you.
Hello, you can hear me? So hello everybody, my name is Jauffret-Roustide. I'm a sociologist and a research fellow at the French National Institute of Health and Medical Research in Paris. And I'm very happy today to have the opportunity to present preliminary results of research that I'm currently doing. And the title of my presentation is The Experience of Violence at the Workplace, the Perspective of Harm Reduction Workers in France. So I will begin with some elements of context. So violence linked to drugs is mainly explained by drug trafficking, but violence is a multidimensional phenomenon and can be also structural and institutional. So people who use drugs, who are attending harm reduction services, are often living in very precarious conditions, suffering from psychotrauma and various forms of stigmatization. So this vulnerability can sometimes give rise to episodes of violence that can occur in the context of harm reduction services. Indeed, the international literature shows that harm reduction work unfolds under violent conditions, which are amplified by the prohibitive regime of drug policies worldwide and by the interplay of poverty, drug use, gendered relationships, and homelessness. So to explore the topic of violence at harm reduction workplace that has been under-documented, we decided to set up a sociological research project in the French context to understand the context in which such violence occurs in harm reduction facilities, the different forms of violence to which professionals may be exposed, their experiences and representations, and the solutions to be implemented. I will now move to the methodological and conceptual framework of this research. So we implemented a qualitative sociological research in Paris that was based on ethnographic observation sessions in harm reduction facilities, and I also conducted 50 semi-structured interviews with a diversity of harm reduction professionals. As a conceptual framework, we use the concept of workplace violence. Workplace violence refers to the unwanted and recurrent acts of physical, sexual, or psychological harm that create a distressing workplace and affect workplace performance. This framework recognizes that violence in interpersonal relationships should not be limited to an examination of physical violence, but must encompass emotional, psychological, and social suffering. So I will now move to the result. So in our research, harm reduction professionals emphasized the violence that is experienced by their clients, people who use drugs, and the emotional distress they received from listening to these narratives at their workplace. Very often, workers expressed concerns about young women, especially women using crack cocaine, who suffer from multiple forms of violence, in particular sexual violence, exposure to sexually transmitted disease, and other vulnerabilities. Workers described this situation as terrifying, occasionally leading to the death of very young people. For instance, a social worker with 15 years of experience described to us in an emotional tone, there was a dramatic case of a woman we followed a lot because she was pregnant, a young woman who was like a child in any case. She was very defensive, very violent at first. With this pregnancy, we were able to support her. Then a second pregnancy, and we were even able to help her terminate the pregnancy with very strong ties afterwards. We are losing this woman. She contracted HIV last year at Porte de la Chapelle, an open drug scene in the northeast of Paris. She was negative for years and then contracted HIV. It was a tragedy. It was violent. All harm reduction professionals that we interviewed described that listening to the testimonies of people who use drugs is experienced as violent. They explain feeling powerless to take care of these vulnerabilities in a context where they described helping clients as central to the meaningful dimension of their work. They emphasize the emotional burden carried by listening and acknowledging that violence events were at the heart of many clients' biographies. For example, a social worker that was new to harm reduction described, I can see that there are some very, very young, very vulnerable women, from a psychological point of view, very fragile, who are exposed to violence. That's not the same as for men who are in an already extremely violent context. For young women, it's often people abandoned by their parents during childhood. Yes, and often under the influence of drugs, often exploited in prostitution networks. I speak for myself as a worker, but as a young professional, I tell myself, there is an identification. I'm not in my 50s, and that's normal. I find the human violence that goes on every day really hard. Afterwards, honestly, you manage to do something and you manage to move forward, but not with all of them. It's complicated, but our objective is there. There is a sense of priority in our missions. In some cases, a sense of despair linked to the gender and young age of clients triggered the perception and experience of violence, as it is mentioned by another social worker. He said, I've never seen so many women on La Colline, another open cocaine crack scene in the northeast of Paris, since this year. It's shocking. Before, we used to see women in their 40s arriving from the West Indies or Sub-Saharan Africa. Now we have girls who are either underage or close to, and who have run away from the children's social services or from their families. Finally, harm reduction workers who participated in our research complained very little about the violence episodes, mainly verbal violence, they may experience themselves from clients in practice. There seemed to be a form of euphemism in the discourse linked to a process of normalization of this type of violence. The second very important aspect in harm reduction workers' narratives of violence lies in their perception of having limited institutional support to harm reduction work, specifically the political and legislative resistance in France to develop harm reduction as a public policy and the limited available resources. These factors enforced a power imbalance which harm reduction workers perceived as indicating the low status of harm reduction work for public and political institutions. For instance, a harm reduction facility manager with 25 years of experience explained during the interview, "We are not making any headway. I'm at the reception desk of my harm reduction facility 5 days a week, and I see what's happening every day. The regional health agency and the city council don't follow up on what we already brought up 3 years ago. It's getting tiresome. It's too complicated to financially support new projects," they, public policy officer, always say. In the same line of this first harm reduction manager discourse, in their description of violence, harm reduction workers emphasized their feeling of having limited consideration for harm reduction work by public authorities, both at local and national levels. They considered that the French drug policy is too much focused on criminalization of drugs and repression and too little involved in harm reduction perspective. The French prohibitive regime indeed creates violence for people who use drugs as well as for professionals. For example, another harm reduction facility manager describes that he often received refusal to develop new harm reduction projects and considers his attitude as a form of violence. He said, "Beyond the repetition of refusal, it's a lack of feedback when we ask to implement new harm reduction projects. We are on a 1-2 year hiatus, and it's very exhausting. We submit projects, but they reject them, and we have no response. We also get incredibly unpleasant arguments on the project we propose. It's very violent to hear." One recent example of this feeling of lack of consideration that was recurring in the interviews are the difficulties that professionals faced for disseminating drug consumption rooms in France despite scientific evidence. So to conclude, in summary, in their description of violence at workplace, harm reduction workers primarily emphasized the emotional impact of witnessing violence suffered by clients, as well as the limited support from public authorities that is perceived as a denial of their work. Our research shows that workplace violence emanates from multiple sources. To date, most research has been primarily connected violence attributed to the behaviors of clients, which may be explained by situations of extreme precarity, mental health issues, stigma, and criminalization of drug use. Certainly, the violence harm reduction workers have to face from clients exist, in particular verbal violence. However, a sole focus on clients' violence inadequately reflects the entire continuum of violence. In fact, our research showed that it is not as much the client's behavior per se, but rather the emotional impact of their narrative that harm reduction workers are exposed to at their workplace. Coupled with the feeling that harm reduction policy is not really the top priority of French authorities, all these aspects reinforce existing inequalities of power and control among workers and increase their experience of violence at workplace. So to finish, I would like to thank all the harm reduction workers who participate to this research, as well as the Fédération Addiction, who give us the opportunity to now expand our research in several French settings in the next few months. I would like also to thank my colleague Guillaume Dumont for our fruitful discussion on violence at workplace. Thank you.
Thank you so much, Marie. We did a session on Monday that spoke to this very clearly about the additional occupational stresses that people working in harm reduction experience. It's not just the vicarious trauma from listening to the narratives, it's all that extra stress because we are not accepted. We are stigmatized for doing this work, right? So that adds to that in comparison to perhaps other, folks working in social services. And one of the things that came out of it, Marie, was that there's not enough research to support organizations to be intentional about the way that they address that for staff, right? And it's not just about training staff to understand this. Organizations need to put lots of different things in place to support their staff's care. So I'm really appreciative that we have extra research for people to be able to justify those line item budgets, right? I'm saying this to those of you that run organizations that say, we have a line item in our budget for self-care for our staff, right? Or general care for our staff. So thank you so much for that. Our final speaker is Daniele from Geneva. Thank you.
Yeah. Thank you, Emma. I want to begin to ask you why just for me the city and for all the others the country? Probably...
I realised that when I said it because in the thing it said Geneva and it didn't...
It's Geneva.
It is, yeah.
Geneva, Switzerland. Yeah, and I will talk about a Swiss history, not just a Geneva history. So I will talk about, am I able to read that? Okay, about, yes, mental health predicts cannabis use. These are the first results of a pilot project we are realizing in the whole Switzerland, not only in Geneva, but the best part clearly is that in Geneva. Usually, when we think about mental health and cannabis use, we think of cannabis use inducing mental health problems. The contrary clearly is also the case, and that's what I will be talk about. Could health issues motivate cannabis use, and could they eventually also be a reason for problematic cannabis use? So in Switzerland, we have had, as elsewhere in the world, an evolution from abstinence-based treatment, abstinence-based politics, towards harm reduction-based treatments and politics, and we have a new phase now since some years, what we call consumption competence. There is a difference between consumption competence and harm reduction. Harm reduction still means the consumption is problematic in itself. Competence means it can be problematic, but often it's funny. And that means that acceptability increases. Acceptability to talk about, acceptability to enter treatments, and acceptability also to change laws. And knowing why people consume cannabis or other drugs may improve or help to tailor interventions, may help to differentiate different risks, because there are different risks, possibly also different risks correlated to different motives of consumption, and clearly will augment the acceptability of policies and programs. So what is known until now about the correlation between mental health in general and cannabis use? We know there are many studies, it's always the same, coping is a bad predictor of cannabis-related problems. Smoking cannabis to cope is a risk factor, is the main risk factor. There are many types of coping. Coping for environment stressors or coping, also for health-related issues. And with regard to health-related issues, there isn't much literature until now. What we know is that users who use it for chronic pain, chronic pain is one of the most commonly reported reasons for medical cannabis use. But they usually report less problems than for other motivations. And also severity of pain didn't correlate with cannabis-related problems. That's what we know until now. So, the Swiss context. Despite prohibition, as almost everywhere in the world, we have one of the highest prevalence of cannabis use. It doesn't work. And even Swiss politics, or part of Swiss politics, acknowledged that and passed a new law some years ago to allow pilot projects, not for medical use, for non-medical use. And they allowed pilot projects everywhere, a little bit everywhere in Switzerland. Now there are seven projects, and we are realizing one of those projects with the University of Geneva. It's called the Cannabinothèque. It's a Geneva pilot project launched in December 2023. You're able to buy cannabis if you live in Geneva. It's clear. It was approved clearly, locally and organically grown cannabis, which is a problem because indoor cannabis isn't allowed. And we have seen that to contrast the illegal market is really, that's one of the problems. And the second, the control of the concentration is much, much harder in outdoor based cannabis. So controlled THC levels also serves as an educational center, and that was one of the main interests of our Geneva project. And it's non-profit. There is a study which evaluates what happens around this project, changes in cannabis consumption, shifts in public health. We do that together with the Department of Sociology, Sandro Katashin, and who is also investigating what is the impact on local criminality and especially the perception of local criminality. So the present analysis is on the first 696 participants. In the meantime, we have 1,200 and we will increase to 1,500. Several informations, a long questionnaire. They fill it out because they have to fill it out to receive cannabis. So for once, it's really easy to let fill out questionnaires. One part is just asking about health. These are the different aspects of health which are measured by the short form health survey, the SF20. A second questionnaire, very interesting one, I think the marijuana motives measure, which measures different types of motives, coping, social means to be together with other, expansion, the intensity, to have the intensity of experience, conformity, typically under peer pressure, enhancement for pleasure, enhancement positive, etc. So what we did is a path analysis, putting in the model all the different aspects of health perception also, defining the consumption motives as mediator variables, and at the end using the QDIT, which measures problematic cannabis use. First result, the direct effects, just mental health was really significant and was negatively correlated with the QDIT. The less healthy, the more cannabis use problems. So low mental health associated with higher cannabis use disorder. And then the whole path analysis, and that remained. It was just mental health which was correlated with the QDIT, and it was correlated through the coping motives. So mental health is the central predictor of problematic cannabis use. When we measure all health aspects, and coping motives is the mediator. So take home 3 pathways to intervene for harm reduction. Improving mental health, that's clear, that's evident. The better your health, the less problem you will probably also have with cannabis consumption. Reducing coping motivated use, even if there is a mental health problem, or other ways to cope. And promoting positive use motives, as we have seen that other motives are related to less problematic use. So if you have a mental health problem, use cannabis, but not for coping motives. Thank you for your attention.
Thank you, Daniel from Switzerland. He's not going to let me forget that now. I know he's not. And thank you again, extra information for our harm reduction toolkits, right? To be able to tailor for that individual in front of us. So we have some time for questions, and I will do the running around. So does anybody have any questions?
Thank you. It's a question for Daniel. Is there any reason why you chose that only people from Geneva could access that service and not people from other cities within Switzerland?
Yes, it's a legal reason, because the projects are locally limited, and in Geneva it's just the canton of Geneva. Other projects are even limited just to the city. They realize it. And not all cantons, how should I say it, are really open for those type of projects. That's the reason, yeah.
Okay.
Also, Daniel, where do we get the T-shirts and the hoodies?
Yes, you can. No, you can't buy them by internet. I think I'll open a site for
next
that.
Conference. Yes, we need to be able to buy them.
My question is also for Daniel. So you used the phrase mental health challenges or mental health problems. I find this is a very broad term. Can you reform more specifically on the negative use for cannabis versus people who hear voices, or people who are bipolar, or people who live with severe depressive anxieties? So I think that I just found the term mental health challenges very broad and not very specific, since people suffer from multiple mental health challenges.
They can suffer or they can have diagnosis, and that's not the same. What we measured, and specifically, we measured their perception and their opinion. We didn't they shouldn't have any diagnosis in order to enter the project. It's really non-medical medical use. So you can have mental health problems, issues, without having a diagnosis, and you can have a diagnosis and be convinced not to have any issues. Did I succeed not to respond?
Yeah, hi. My name's Colin McGregor-Patterson. I just wanted to kind of connect. Emily, your presentation was just fantastic, mind-blowing, and you're really on something. I'd really like to have that chat with you later on, but I'd be interested to see this time next year or the next conference how neurodivergence will really impact your presentation, Mr. Geneva. Sorry, I didn't catch your name. But the sort of links are substantial and massive, and we do need to do something far more quickly around identifying neurodivergent conditions. Working in drug field, lots and lots of our clients, young clients, are cannabis smoking, but that's to deal with their conditions. So it's kind of, I couldn't quite see that in your presentation in relation to supporting mental health issues. And obviously then you have this issue of sort of people using cannabis going down the criminal justice pathway, which is why we've kind of got such high numbers of people in prison with ADHD and diagnosed and undiagnosed, and also a substantial amount of people in drug and alcohol treatment have got undiagnosed or diagnosed ADHD, and I think we seriously have to do something different. So, well done everyone, but Emily, I think you're definitely on something then.
Thank you, Colin, and thank you for mentioning the prison populations too. It's something that I think a lot of people don't see, but it's so salient back home. So appreciate your love and Afi, and I just think it's awesome to see that there's people like yourself working in the field who are seeing our people and seeing their experiences and wanting to validate that. And here's to more research in the future, I hope. Thank you, Colin.
Yeah, and just to add to that, the number of people that said to me before the session how interested they were, and I think that speaks to the number in this topic, speaks to the number of people in the room on the last day of the conference.
Hello, my name is Ben Collins. I'm with Reshape, and I really want to thank you, Emily, too, for your presentation, and perhaps to drive this a little bit home. I think I'm amazed that somebody who's living with ADHD has adverse childhood events and a whole series of things that really led to my HIV infection, that it is so under-discussed in these areas. And I know, for one, that this really varies by country. Many countries are completely dismissive of ADHD. Many other countries, often people who have high levels of substance use and come from colonial backgrounds, are much more open to talking about these things because of the realities and the intersectionality between ADHD, neurodivergence, substance use, abuse, and all of that. That's one point. The other point is, I'll just read something very quickly. Justice is that people with ADHD have an incredible sensitivity around justice, and it says this heightened sensitivity can manifest in stronger emotional and behavioral reactions to unfair situations, potentially leading to both pro-social behaviors like advocating for justice and potentially more challenging responses like impulsively reacting to perceived wrongs. I just would like to tie it into Marie's comment about violence in situations. I can't tell you how difficult it is knowing I'm HIV, that I have ADHD, working with activists who are untreated and are not aware of their own ADHD. I'm very aware of the kind of violence, the kind of things that happen, particularly in our types of organizations, with people leading to cancellations and to argumentations. And it's really a failing that we aren't linking these together. But I would say this conference is so much better at dealing with these kind of intersectionalities than we are in HIV, where most of what is being said in this conference would never be allowed in most of the HIV conferences, blatantly because it's so prevalent in those situations and people really don't want to talk about them. So thank you again. Great job.
Thank you.
Can I just acknowledge that Patsai, that conversation was beautiful. I feel really emotional hearing it. Thank you so much, my friend. Solidarity.
Thank you. Someone on the front? Yeah.
of all, thank you all for being here, for coming from so many different countries. As a Colombian working in New Zealand, I feel very honored and very grateful that you all came. I also am witness of Emily's work, and I know there's a lot of things that will happen in Aotearoa that will improve life of those living with HIV, with ADHD. Potentially, I think things will improve. So I encourage you all to sort of try to work and support people who are neurodiverse. There was a study about HIV, and the quality of your life depends on the amount of stigma that you experience. So thank you so much to I forgot her name. Philin, about your study, because the quality of your life depends on the amount of stigma, and I think we often underestimate that. And about you, Marie, as a doctor working in addiction, I have experienced a lot of violence, and it's often like, yes, we have to accept it. Is there anything that we can do to try to kind of make things better? Like, I have patients walking into my doors with knives and things, and it's almost like, what can we do? Because the vicarious trauma definitely exists, and I do feel that our peer workers are often exposed. So that's my question. And to you, I was going to ask you, in terms of the mental health sort of scores that you have, what would the age of your population? Because we know the earliest you use cannabis, the higher the risk for mental health issues. Thank you so much to you all.
So I will answer to your first question on violence. So in my research work, there was a very huge gap between what I observed during ethnographic session and the narratives from the semi-structured interview from harm reduction worker. I was very surprised that during ethnographic observation, I see that they have to face, as you said, a lot of violence from clients, mainly verbal violence in France, but sometimes also physical violence. But I was very surprised that during the narratives, they don't put that in light. They prefer to say that listening to the narrative was something very violent, that was a more important violence for them compared to having to face verbal violence. So, regarding solutions, that's difficult to answer, and the project is still ongoing. But I think that something important is also to address why people are violent. So people are violent also because they live in very precarious conditions. That drug use is criminalized, and some of them have also to face serious mental issue. And if we don't address all of these topics, nothing will change. So that means more money for harm reduction services, and the possibility for harm reduction services to have more workers in their services. So it means structural changes.
So the question about the age of participants. The mean age, if I remember well, for this first sample was 45. Yes, and that's one of the most astonishing results we have. Many were young, but many were much older even than 45. And it was a real diverse sample. And another astonishing result was more than 50% were academics. Yes, and that was clearly not expected, and not only in Geneva, also in the other projects. And there were also some police officers.
So you think academia is linked with lower mental health?
No, it's linked with the. No, definitively not. It's no, and we. No, I don't think so. And we introduce also for other analysis also age and gender, and it didn't change the results. No.
And gender?
No. No. Yes. coping is still the problematic motivation. Yeah.
My question is for Emily as well. So I really appreciated hearing what you said, and also I wanted to add that I recently heard about a study that looked at like younger kids being treated for ADHD and how the correlation with substance abuse really goes down in those cases. I've heard less about like treating it in adulthood and if the same trends continue in that way, but definitely going to be following along with the research. My question is about grouping the ASD and the ADHD research together. You kind of mentioned it a little bit, how it's really hard to generalize really about ASD on its own. It's hard enough. So do you see any advantages to looking at those two together, or is it just because this is the beginning and they're trying to like lump everything together?
That's a really awesome question, and I so recognize the irony in talking about them separately when they are so interlinked and there's so much comorbidity. I think recently, obviously in the first world, I want to acknowledge, of course, that even accessing diagnosis for third world countries, for countries experiencing genocide like Palestine, is not even achievable. But in first world nations, I think there's a little bit more of a recognition of the kind of coexistence of the neurodiverse spectrum, and I think there is real value in looking at research kind of from a wider lens and looking at people who just have ADHD, people who have autism spectrum disorder, people who have both, maybe people who have co-occurring mental health conditions. Because I totally agree with you. I also think that studies that show treatment in adulthood for things like ADHD, they're most effective for people who only have ADHD. And when you add autism into the mix, when you add mental health into the mix, when you add trauma and intergenerational trauma into the mix, it becomes a little bit more blurred to establish that. So I really appreciate that comment, and I think it's something I would love to see in the future. I think it's a very new area of research still, and there's a lot of gray area, and it's a really difficult population to engage with, but it's something that I think would be fantastic. So yeah, I appreciate that comment so much, and thanks for being here.
Thank you. Any final questions before we wrap up?
Thank you. Hi, my name is Melissa. I have two questions, one for Emily, and the other one, can you remind me your name, please? You? Philin. Thank you so much. So for Emily, the question is, in New Zealand or other countries, have you noticed any link between trauma and how it leads to certain diagnoses? For example, ADHD or any others? And for Philin, the question is if you have ever studied stigma in corporations.
That's a fantastic question about the trauma. And I should say in Aotearoa, New Zealand, there's actually no research on ADHD and substance use. Not even a single paper. So he's like, I believe it. What I'm speaking from is my experiences in engaging with people. But I think, what was mentioned before is that there's kind of many people with ADHD and ASD experience trauma in their lives. And I think sometimes it's a product of not being understood. For me, my experiences in my life were really shaped by having ADHD, and a lot of the trauma that I experienced as a child, I now reflect to not being able to make sense of those experiences within the context of my neurodivergence. But as far as research goes, the trauma-informed care side of things, as well as ADHD and ASD and diagnosis and substance use disorder, is something that I haven't really found any evidence on. But I think it's something that's really worth exploring, and I think we can't neglect to see trauma as an integral part of that experience. And so I think that that's a really important observation to make, and I didn't mention it in here, so thank you for bringing it up.
ก็ขอบคุณสำหรับคำถามนะคะตอนที่เราพัฒนาโปรแกรมเนี่ยเราตั้งใจว่าอยากจะให้โปรแกรมเนี่ยเอาไปใช้กับคนทำงานภาคประชาสังคมที่เขาเข้าถึงกลุ่มประชากร ที่เป็นเพื่อนเราเป็นเพื่อนผู้ใช้ยาอยู่แล้วเพราะว่าการที่เขาเข้าถึงกลุ่มประชากรและมีโอกาสเจอบ่อยขึ้นเนี่ยเขาก็จะเอาโปรแกรมตัวเนี้ยไปทำกับเพื่อนได้ต่อเนื่องมากขึ้น
Okay, so what she said is that thank you for the question, and the program was designed not only for the peer communities, but also for the peer providers as well. So most of the peer providers will be from NGOs who work closely with people who use drugs in Thailand, and their backgrounds is very diverse. They believe that those who receive the trainings as a peer recipient of the services, they will gradually become the peer providers as well, and we will see that the growth from being a recipient of the services, they will also become a providers in the future.
Okay, one more. Oh, we have you as well. Okay, we might have time. Yeah, thank you.
I'll be very fast. I didn't mention that earlier in the conference, Tatiana Dushko from Ukraine showed a really interesting study about substance use and ADHD, and was measuring 40% of the population she studied had ADHD. And this may be counterintuitive to you, but I found ChatGPT one of the best resources when trying to ask these questions that are understudied, because they're very good at talking about associations, and you can ask questions and much more honest than our own communities when we talk about some of these issues, because this is a very divided issue inside of our communities.
Okay, I think with that, we'll bring our session to a close. Please give our presenters another round of applause. And thank you to you for sticking with us through the end of the day. Please, safe travels home and enjoy your last night here at the conference. Thank you.
Thank you.